Good morning, everyone. Thank you for joining us at our next educational session for our annual meeting. I'm very happy to have all of you here. We've had a lot of great sessions already yesterday, and we have more later today that we hope you can join, and we'll certainly share those with you at the end of this presentation and look forward to seeing you all there. So just to get us started, my name is Joshua Christiana. I'm the Director for Quality and Compliance and Chapter Relations, and I'm joined by Kate Guerin, who is our Director of Public Relations Communication. So a couple of housekeeping notes for the day, and I'm already skipping around testing out Kate's ability to follow along with me here. So just a couple quick housekeeping notes. Everybody's on mute. We'd ask that you stay on mute. This session is being recorded. And if you do have some questions, certainly drop them into the chat box because we'll keep an eye on that. And we'll definitely save some time for us to answer any of your questions at the end. But on this slide, you can see our contact information is here. So if you don't get a question answered today, you're welcome to reach out to us either email or phone, and we'll do our best to get back to you as soon as we can. Next slide. So we have a fairly robust agenda today. This is really the first time that we've addressed the organization as a whole on our COVID-19 experience over the last 18 months. And while we recognize that many of you probably have COVID fatigue because you've been living it and you've been in meetings talking about it and you've been doing your own planning on the ground level, we felt that there's a lot of value in us talking about our collective experience and how specifically data has been valuable in informing our decisions and our actions. And this is really one of the most significant things that we did over the last 18 months. We've really moved as an organization more towards a data-driven organization, and that's reflected not only in our COVID-19 response activities, but also our strategic plan. So today we're going to talk about our experience. We're going to talk about the data project and how we designed it. We'll talk about our important relationship with Syracuse University, how we reported out on our data. We received lots of media and academic coverage, which we'll go through, some positive outcomes and lessons that we learned, and we'll leave you with some COVID-19 resources that hopefully you'll be able to leverage going forward. Next slide. So really to get an understanding of sort of where we went with the data, we have to talk about where we started. So our early experience with COVID-19 really began in March 2020, 18 months ago, if you can believe it. That was when the state of emergency was declared in New York State. And you can see that pretty rapidly there was a reduction in operations and our routine activities across the state. Notably, day program closure happened not too long after the state of emergency. So we were really focused on operational efforts and reacting to something we had never experienced before. And on top of that, the state of New York and the governor issued several executive orders that reduced our workforce in-person activities. So lots of transition going on early on. Lots of, trying to figure our way out through this process and not really entirely understanding what was to come. Next slide. So almost immediately, the very first challenge that we experienced related to personal protective equipment. And that is really the first event that drove us to consider the value of data in the public health emergency. The CDC and the New York State Department of Health were issuing guidance on universal precautions, and they were requiring us to use personal protective equipment. And of course, the challenge in that was that there was a limited supply of PPE, including gowns, gloves, and several other resources. There was also competition going on between healthcare providers to access this. So, we were struggling with sourcing personal protective equipment. There was lots of supply chain disruptions because people were not prepared for the volume of resources that were needed and being requested. We were left with some options for local sourcing with the health departments, the healthcare partners such as hospitals, the Office of Emergency Management, and then national distributors. But that was very challenging because, again, some folks were not really aware of us, and we had to educate them as to what we do. And then at the end of March, we ended up conducting our first survey and initiating bulk ordering, which I'm going to get into in a second. Next slide. So it was exactly 1 month from the date of the public health emergency where the governor issued the executive order that required healthcare providers, including us, to look at the inventory that we had, and any inventory that we held had to be reported to the Department of Health. And DOH was authorized to shift around any of our inventory as needed to help fill any gaps at other healthcare facilities, such as the hospitals. So again, you can probably recall that this created some more challenge for us, because now it wasn't just, hey, we have this limited resource, but this limited resource may need to go to other locations more immediately. Next slide. So again, Department of Health had the authority to return the inventory at their discretion. And so we didn't really experience that right away, but it certainly put pressure on us to really know what inventory we actually had. So this is sort of where we first started discussing, well, how do we obtain this information? What data do we actually need? And on April 8th, we issued a survey out to the chapters, which was the first one we did in COVID and the public health emergency, where we asked for an inventory of PPE. Chapters were great and quickly got us the information that we needed, and which was a good thing, because shortly thereafter, another executive order was released that required employees to wear face coverings and masks, and that obviously led to an increased demand for those supplies. Next slide. So after we got the inventory and the data, we were able to turn that around and start doing bulk ordering. And these are just some visuals of our office here, where we were using some of our space to kind of store that inventory, and chapters were coming out and picking up their supplies. We were able to successfully do this statewide, and we've never really done that before. So this was a pretty big undertaking, but we had quite a bit of success. In fact, we were able to acquire about $3.2 million worth of PPE to date for the chapters. And thanks to the good work of our finance department, we were able to access some FEMA funds and private grants that have allowed us to get reimbursed at the cost to the organization. So again, this was a huge undertaking, but it was driven by the data that we collected from the chapters on their PPE supply, and really is the first example of how we were able to leverage some information quickly through our operations. Next slide. So the lessons that we got from that is it really just reinforced that the data is readily available. Chapters were able to quickly produce the counts of the PPE that they had on hand. And we learned really quickly that this should inform our decisions, right? That data should really help us determine how we can respond to public policy, how we can make requests for additional support, and how we can operationalize the data. So, and that was done through our central purchasing. Kate, can you just jump back a couple slides quick? We also were able to improve some of our outcomes, including our operational efficiencies and our advocacy on public policy. And most importantly, what this did was it really started our stakeholder involvement and engagement. Again, the chapters were at the table the whole time, helping us gather some data and helping us guide our process. So this next set of slides is really going to walk us through the project. And the goal here is that you'll be able to walk away and think about how you might design your own data project. We're going to use our COVID experience as the example, but the elements here that we're going to talk about really can be used in any way that you are looking to collect data and use it towards any of your projects. So we have been doing data collection for several years. Our work includes exploring topics such as staff turnover, allegations of abuse and neglect. We've collected data on financial sustainability, all sorts of different areas. And there is no one real path to a successful data project. However, there are some consistent elements that you'll find wherever you are collecting data and analyzing it. So again, these next few slides are going to cover some tips related to each element here. They can apply to one-time requests for data, or they could be longer projects, such as the COVID-19 project, which went longer than a year. But it's important to understand that your data project is going to have to scale up over time. So it's perfectly acceptable, and it's often a good strategy to start with a small data set and build upon early successes and adjust as setbacks occur, because unfortunately you will experience setbacks. But again, start small and work your way up. Next slide. So there are some questions that you want to explore as part of any data project, right? So we decided that we were going to look at how is COVID-19 impacting the people we support. And the basis for any solid data collection and analysis starts with a question or a hypothesis. So if you don't create that element, you'll end up collecting all types of data that, while it might be interesting, may not present real value in the end. So you really want to make sure that you have a solid hypothesis to start. And we eventually added a question about the impact of COVID-19 on our employees, but we felt that we should start with the impact on the people we support. You could create a hypothesis in this situation involving people with intellectual and developmental disabilities, looking at, are they at greater risk to the effects of COVID-19 than the general population? And later on, Kate's going to talk a little bit about that when we talk about our relationship with Syracuse, because that was their hypothesis. But all your data collection should return back to addressing the hypothesis or the question at hand. You definitely need to have some stated desired outcomes. And aside from attempting to answer your question, understanding how you'll use the data is equally important. So you might intend to use it to generate reports, influence public policy, rally stakeholders, there's many activities for this. But our stated outcomes were to use the data to inform our operations and advocacy efforts. Operationally, we wanted to understand how COVID-19 was progressing amongst the population we support. And as an example, we wanted to know when we might have to suspend operations based on the growth of the virus in a particular region of the state. So that's kind of how we were looking at the data. We also gathered it to help us with advocacy and advocating for resources and equal access to personal protective equipment. You also want to look at the audience that you're addressing. So as you're identifying the questions and your outcomes, identify the audience that you hope to address. And for us, we were looking at addressing our state partners, OPWDD, the Department of Health. Obviously, we wanted to address the chapters. If your outcome is to rally stakeholders, then your audience may be the community and family members. So it's really important to target that right audience at the beginning so that you have a chance to achieve your stated outcomes. So a couple more elements here. The available data set, very important. You may have access to thousands of points of information because really all you need is the internet and you can find a ton of information. However, the data collection you're doing needs to not only come from the available data sets, but also reliable ones. So the internet isn't always the best option here. If you're a healthcare provider and you're conducting a study on public health policy, you can look to internal records you have on the people that you support, but chapters maintain records. So as an example, we were able to quickly gain access to information on the number of COVID cases that we were experiencing across the people we support. You can also look to external sources. We used the Department of Health data quite frequently, and we relied on that throughout the project to kind of get a sense of how we compared to the general population. And then the last two elements here are require you to look back at the question or the hypothesis that you developed. And because we were working on the hypothesis, looking at people with developmental disabilities being at a greater risk to the effects of COVID-19 as compared to the general population, we initially requested data on case counts for people supported, as well as quarantined employees and the people we support. So we really had 3 data points. And this kind of goes back to my earlier comment about making sure you start small, because you'll notice as we go through the next couple slides, we built upon that. And if you want reliable data and sound results, you have to clearly define what it is that you're asking for. And you can't leave your request open to interpretation to the respondent. So really spend some time up front working on your definitions, because that'll help the respondent be able to navigate through the data points that they have available and make sure they're getting you the most valuable ones that will help you answer your question. Next slide. So you want to establish a frequency for your data collection. You could collect once a year. You could collect quarterly, monthly. In our case, we chose weekly, which was ambitious. And we weren't sure how that was going to work at first, but the chapters, again, were very helpful and able to get us the data. But it really depends on how regularly the data is going to change, right? So you have to consider survey fatigue, make sure you're not over surveying. And we based our weekly collection around our weekly meetings with the chapter leadership. And that allowed us some time to be able to collect the data, review it, analyze it, and develop some reports. The platform that you use to collect your data is very, very important. SurveyMonkey was great as a start because we were able to very quickly gather some data. It was an easy way of collecting information. It isn't a data warehouse, so that was one of the drawbacks. But if you're planning to do a single request for information, then SurveyMonkey might be an option for you. But if you're looking for a longer data project where you're housing that data, you might want to look to a different more robust platform. We ended up using our chapter information system, which is where we collect all of our quality data, some of our financial data, and that allowed us to kind of generate more robust reporting. And then lastly, you want to have some clear standards for reporting to your stakeholder. Anytime you're involved in data and data projects, you want to make sure that you have a deliverable. And to increase the buy-in, you need to commit to reporting back results. So we committed to weekly emails. We analyzed our data. We were sending out emails on Monday. And then we were at our Wednesday meetings with the chapters. We were reporting out those results. And it really helped us kind of grow the project. Next slide. So just briefly, you can see here that we started to survey the chapters at the beginning of March, and we had a 90% response rate, which was fantastic. But as commonly experienced, we did see a decrease in the response rate as the surveys kind of continued. People are pretty generally willing to provide data up front, but then, unless there's a clear sort of deliverable right away, you can also get some fatigue right away, and then you start to get a response rate that reduces. But we added a data point. You'll see that, and then that was important to our project because we wanted to know more about our employees and their experience. But we quickly realized that we wanted to know more about the workforce because they are the foundation of what we do. Next slide. So Kate's going to talk to you a little bit about what we did once we had that data and how we leveraged it with some advocacy. Kate, I think you might be muted.
Thanks, Josh. Once we had the data, we immediately took the result of our initial data request and turned it into talking points to advocate with state policymakers. We wrote a letter to the governor on April 1st, 2020, leveraging our data to express the urgency for the state to take action in supporting our pandemic response. The letter reads, as of noon today, we have already lost 6 individuals we support and 2 of our frontline workers to COVID-19. Hundreds of people we support are already ill. Hundreds of our staff are already in quarantine. You'll notice that we mentioned the number of fatalities we experienced. This wasn't part of our original request for data, but our chapters understood our goals and they provided us with additional data that we hadn't even asked for through the formal process. After we sent that letter and shared it with our stakeholders, we had a notable increase in survey responses. We were building buy-in by demonstrating that the data was being used to further the mission of this organization. We also continued to evolve the survey through April in response to the changing environment. We added data points on fatalities, hospitalizations, and recoveries. This brought our data collection in line with some of the publicly available DOH data. Throughout April, we expanded our data collection efforts in collaboration with other providers across the state. This greatly expanded our data set. It opened doors to partnering with people with additional experience in data analysis, and it brought new resources to forward our advocacy goals. Our collaboration with NIDA also directly led to a partnership with the Lerner Center for Public Health Promotion at Syracuse University. While it's not essential for every data project, an academic partnership can enhance your data collection and analysis in several ways. By partnering with Syracuse University, we gained access to their professional staff, including specialists in the study of developmental disabilities, such as Professor Scott Landis, who you see here. Our partnership with Syracuse began about 2 months after we started collecting COVID-19 data. At the time, Syracuse was already studying the impact of COVID on people with IDD. A previous study by Scott Landis found that people with IDD have higher prevalence of comorbid risk factors associated with poor COVID-19 outcomes. Our partnership was mutually beneficial because Syracuse didn't have a data set available from providers who are working directly with people with disabilities. Access to our data furthered their ability to test their hypothesis. After partnering with us, Syracuse was able to publish 2 more studies demonstrating that people with IDD living in residential group homes were at greater risk of severe COVID-19 outcomes compared to the general population. This was true for both case rates and case fatality rates. All of this was driven by our data set that was made available to Syracuse. And Josh is going to take it over again for data reporting.
Thank you, Kate. So earlier, when I was walking you through the elements of the data project, we spoke of the challenges of sustaining interest in a data project. But one of the key tools that you can use to achieve sustained interest is delivering routine reports to those involved in the project. And over the next few slides, we're going to look at why that's important and how we did that in a very simple way. Next slide, please. So again, kind of honing in on this point, deliverables are really critical to sustaining respondent involvement. And we committed to the weekly meetings with the chapters and included data reporting as a standing agenda item. You want to make sure that the routine reports are easy to read and share. And we included very high-level reports in our weekly reports to ensure that the organization could easily absorb the results and make decisions. We also provided links to more comprehensive reports through the Department of Health and other sources. We made sure that we shared all of the raw data because we felt that that would be helpful as far as ensuring we were transparent. And the one thing you want to keep in mind there is that you want to make sure that the data is harmonized before you send it out. And by that, I mean, you have to walk through your data points and make sure that they make sense. So there's a bit of work that goes into that, but it definitely lends to the value and accuracy of the data. And it also allowed our chapters to be able to do further analysis. You want to consider de-identifying the data prior to sharing. Some of the information may be sensitive to the relationship to the party that you're sharing it with. A written data user agreement is often necessary, and I can't stress that enough. This agreement will allow the sharing of data after it's collected, and it might include an agreement to de-identify the data prior to publishing any reports. And if you're working with an academic partner, you should absolutely ask for an agreement to be developed. You can develop your own. We have some examples if you would need one. And lastly, trends are really important to identify and share. And you can do that with some very basic charts that give an overview of the study that you're doing, how it's progressing. And in our case, we use them to inform the chapters of our operational decisions. Next slide. So this is really just a visual of kind of what we did. Again, very simple, high level, but you can see that it was able to tell the story of where are we in our COVID experience. So we reported out on the impact to the people we support, how many people were quarantined. We also were reporting out on fatalities week to week. So again, to kind of get a measure, a sense of the environment that was out there. Next slide. And we also took that to our vaccination data collection. We started doing that in the sort of the second half of the project once the vaccine was available. And we looked at both people supported and employees. And similar to how we were reporting out on the COVID data and the infection rates, we started reporting out on the vaccination rates. And this was used to help us gain some priority access to the vaccine, which I think Kate is going to talk a little bit about later. So with that, I'm going to turn it back over to Kate, who's going to go through how we use the data in our messaging.
Hi again. Yeah, so what do we do with all this data? It's operationally valuable, there's no question about that, but it also has great potential to influence opinion and drive change. When data is clearly presented and appropriately interpreted, it can be a powerful tool to educate decision makers about issues and empower them to enact good policy. When we designed the COVID data project, we intended for the data to inform our advocacy in addition to our operations. We kept our advocacy goals and our public audience in mind as we designed questions and identified our data needs. The data confirmed our hypothesis that people with intellectual and developmental disabilities are at greater risk of COVID-19 than the general population. This gave us clear, quantifiable evidence of our need and strengthened our call for support. It's important to note, though, if the data had not confirmed our hypothesis, that too would have informed our advocacy. It would have redirected our efforts to accurately identify and address other challenges. But the data did confirm our hypothesis, and we needed to put those conclusions to work. We needed to distill all that data into a clear and accessible message. We drew from the data to develop key talking points and fact sheets for state leaders, and we shared them with chapters, families, and self-advocates. We identified our issue, that individuals with IDD are at higher risk of infection and death from COVID-19, and we presented our evidence. The data showed that compared to the general population of New York, individuals with IDD supported in residential settings were 4 times as likely to contract COVID-19 and 2 times as likely to die. The partnership with Syracuse University significantly elevated our message. Not only did we have third-party validation of our data, we had an independent, unbiased voice drawing impactful conclusions. Author Scott Landis concluded that the policies enacted by providers were effective, that continued robust data collection is crucial, and most importantly for our advocacy efforts, his report stated that to address this increased risk, it is necessary to ensure that people with IDD and those who provide for their care have access to preventative measures and the resources needed to carry them out. Think of the difference here. We weren't saying we reviewed our own internal data and concluded that we need more resources. The Syracuse University Lerner Center for Public Health Promotion published a peer-reviewed study on our data. That study concluded that New York's IDD providers need resources to support an effective pandemic response for our high-risk population. That validation makes a world of difference. So in addition to our message, we developed our asks. We leveraged the data and the compelling conclusions from Syracuse University to advocate on key issues to enhance our COVID response. You can see those issues outlined here. These messages mobilized advocates and supported multifaceted advocacy campaigns, including direct advocacy with the Executive Chamber and OPWDD, published op-eds, and a public letter writing campaign in which our grassroots network made more than 15,000 connections with state leaders. The data gave us ammunition for our advocacy. Of course, it's important to remember that data is subjective. Yesterday, I received my morning email from the New York Times, and it contained a story on Colin Powell's death due to COVID-19. The lead of the article reads, "Colin Powell's death at 84 underscores the continuing risk that COVID-19 presents to older people, even if they're fully vaccinated." Shortly below that, a bar graph illustrates the risk of COVID death compared to other causes of death for older Americans. So the graph itself is a little problematic because it breaks the demographics down differently for COVID versus non-COVID deaths. There are 3 age brackets for the non-COVID deaths and only 2 for the COVID deaths, which skews the visual representation of the data. People tend to take in visual information in total, so inconsistencies like this in data messaging can be misleading. We're big on integrity here at the ARC New York, so I guess what I'm saying is that you can expect better from us than from the New York Times. All that aside, the Times analyzed the data, they drew accurate conclusions, and they presented a message around those conclusions. Their message is understandably unsettling, particularly to older Americans. Even if you're vaccinated, you are still at risk. The New York Times story used 2 data sets, the CDC National Mortality and Population Data from 2019 and annualized COVID data from 16 US jurisdictions during the week of August 29th to September 4th. But you can analyze those same base data sets and convey a different message. Here you can see I made a different graph and wrote a couple of alternate headlines. You could look at this same data and say, data shows COVID vaccination reduces risk of death in older Americans by 93%, or that the current average risk of death from COVID for a fully vaccinated American between 65 and 79 is 0.12%. Where the Times message feeds anxiety, these conclusions are a little more reassuring. All of them are accurate, and all of them are supported by the same data. In crafting our message, we look not only at how our data could forward our advocacy, but also considered how the same data could possibly be presented in a conflicting way. One possibility was that the poor outcomes for individuals with IDD in New York's residential settings could be attributed to poor response by providers. So in addition to our key talking points, we outlined our COVID response in depth to ensure we were fully prepared to address those claims if they were made. Whenever you're messaging around data, you need to anticipate and be prepared to refute counter arguments that can be drawn from the very same data you're presenting. Data, and in this case, specifically COVID data, is a powerful tool. That being said, statistical data only gets you so far. There are folks out there whose job it is to collect and analyze data on data. Of particular interest for communications and advocacy is the study of how data influences people. You can see one conclusion here. Whereas statistical evidence had more impact on beliefs and attitudes than anecdotal evidence was found to lead to higher levels of intention than statistical evidence. In short, statistical evidence convinces people there's a problem. Anecdotal evidence makes them want to do something about it. That fusion of anecdotal and statistical evidence is what gives your message power, and that's what we aim to do in pitching this story to the media. We know that state leaders react to media attention, and we know media can be used to influence public opinion and drive positive change. If people are interested enough to read a story about the findings of your recent data project, it may convince them there's a problem, but it won't make them care enough about it to take action. That's where anecdotal evidence is the winner, the compelling human stories. You meet a person who's at risk, a family who lost a loved one, a DSP who is exhausted by long hours and fear and grief, and their story is what connects you, what makes you care. Their story is what drives your intention to call for a solution. So when we pitch a public message, a press release, an op-ed, we bring the statistical data to them to demonstrate the problem, and we bring the human stories to them to make it matter. Both are equally essential to crafting a strong call for change. That's the tactic we took in driving media coverage on the data project, and it was effective. The Syracuse studies were cited in more than a dozen stories on the elevated risk of COVID for the people we support. People with IDD supported in residential settings are 4 times as likely to contract COVID-19 and 2 times as likely to die. We convinced people there was a problem. More importantly, we convinced them to support our solutions. Our data collection and the reporting on our findings drove advocacy at the federal level. The United States Senate Committee on Health, Education, Labor, and Pensions cited NPR's coverage of the Syracuse study in a call to CMS to expand federal COVID-19 data collection to include data on congregate care settings for people with IDD and other disabilities. Their letter states that data collection is critical in order to respond effectively to COVID-19, save lives, and protect our population. U.S. Representative John Katko cited the findings from the Syracuse study in a call to prioritize vaccination for all Americans with IDD. And at the state level, you saw the advocacy talking points earlier. Everything in orange here represents a positive change. We realized success in securing vaccine prioritization, access to and funding for PPE and COVID testing, FEMA eligibility, improved data sharing and transparency from the state, continued support of flexible service modalities, including telehealth, and increased urgency in providing guidance for our field to enhance our COVID response. We continue to recommend right-sizing facilities like single bedrooms and to advocate for hazard pay and federal funding to support our workforce. We are more confident now. The attention drawn by the data project has elevated awareness of the impact of COVID on our population, and we're hopeful that that funding will be realized. We've learned without a doubt that the right data can drive the change we need. And back to Josh.
Thank you. So now that we've looked at how to design a project and we've looked at how to message the data and how the advocacy efforts were successful, we're just going to talk to you a little bit about the project conclusion and what we really learned through the process. So next slide. So Kate did a great job going through some of the interest that we received from different levels of government, federal, state, but our state oversight agency, OPWDD, also had interest in our data. We received outreach very early on in the process from the commissioner proposing that we partner on a study. And specifically, they wanted to concentrate on the ARC chapter data because we had a very high response rate, over 95%. We had a large set of data, and they knew that they could rely on the information that we had. And they were looking at it as 40 separate case studies. So it was an interesting proposal. We agreed to participate in that. And then in June, we did a presentation to the chapters on what we were going to be looking at. Next slide. So OPWDD had a hypothesis that higher quarantine use would lead to more rapid clearance from COVID-19 cases. And conversely, lower rates of quarantine use would sustain the COVID cases and lead to more challenges. So they were able to utilize some of our quarantine information to look at how successful we might be as an organization. And what we determined and found was that indeed the use of quarantine certainly was helping chapters clear cases much more rapidly. And a lot of the chapters were using quarantine as a self-measure to try to protect the people we support and our staff, even beyond any directives from the Department of Health. So we were really sort of leading the way there. And the data that we had was able to support that. So the point of all of this is that the state certainly was interested in the work that we were doing as one example of how another stakeholder might come your way. Next slide. So as of today, we have concluded the COVID-19 data project at the state office level. However, chapters still continue to collect data of their own, and they're reporting out to OPWDD. And we obviously have built a foundation for restarting the data collection if we needed to, which is always important. But if you remember, we started with 3 data points, and that built up to 27 unique data points, which gave us a lot of great information. We ended up addressing infection rates, quarantine use, hospitalization and fatality, recovery rates. So again, a pretty broad set of data. We also collected vaccination data that I mentioned earlier, and that really helped us with our advocacy and getting some early access to the vaccine. And we have a live database for ARC chapters, so they can continue to report into the system, even though we are not using it at the state office level at this moment. Next slide. So just to give you some ideas of some lessons that we learned that you can walk away with today. Again, you want to make sure that you're identifying clear desired outcomes right at the beginning. That will help you avoid mission drift. So you'll stay on task, you'll know what you're working towards, because it's easy to get caught up in interesting data points and then get sidetracked. Those data definitions are so important. Without them, you're going to get a lot of questions about what it is you intended to collect from someone who's responding to the survey. So make sure you spend the time up front on those. Again, identifying a versatile platform for data collection is important. You want to make sure that it is meeting all of your needs and the needs of the respondent. As Kate pointed out, while it's not absolutely necessary to have an academic partnership in all data collection projects, it is very helpful, particularly if you're working on something that is involving public health and you don't have the expertise in your organization. You may want to reach out to some local institutions and see. A lot of schools and universities have researchers that are just waiting to kind of do this sort of work. So certainly looking at them is important. Deliverables will continue to help you gain and sustain buy-in, which is hugely important to the project. So make sure you've identified how you're going to report back to your stakeholders. You have to be ready to change course. We learned throughout the process that our data points needed refinement, our definitions at times needed refinement. The state would change policies, or the CDC or Department of Health would come out with new information that changed how we looked at COVID-19. And all of that led us to continuous change. So just be prepared for that. Make sure your stakeholders understand that that's something they should anticipate. And probably the singular most important thing for you to remember with any data project is the importance in persisting. It is going to be challenging. You'll have challenges in getting the data. You'll have challenges in cleaning the data up. But if you stick to it, you can get some really good outcomes. You'll answer some really good questions that you might have, and you'll be able to build upon the work that you're doing as an organization. Next slide. So while we've concluded the COVID-19 data project, again, the chapters are continuing to collect their data. We, as I mentioned, have been doing data collection for several years. In fact, our quality improvement program is collecting quality metrics into our 8th year. Our strategic plan, several of the components of it rely heavily on data as we move towards a data-driven organization. And the biggest challenge that we're facing at the moment is the workforce shortage. And we have engaged with both NIDA and our chapters to explore some data points that will help us better understand the environment that we're in, our workforce. We're currently putting together a survey to collect some demographic data on our workforce, which will help us with our discussions at the state level and help us influence public policy. So be on the lookout for that. And the challenge here is that the direct support occupation is not represented by a standard occupational code through the Department of Labor. So that limits the available data that we have to us. But that is something that several groups are advocating for. Our hope is that we can certainly push the messaging that it is important to have information on our workforce, both state and national information. So that's something else that we're working towards. And next slide. So just to conclude here, if you go to our website, you will find tons of great resources on COVID-19. Next slide, please. So there's a link to our website. We have over 140 informational updates. It continues to grow. We've been sending them out a couple a month at this point, but it covers everything that's kind of gone on from the state level, the guidance. So if you're looking for all that information, you'll find it there. A lot of the academic articles and things that Kate covered are also there. There's a section on that. So it's a really great resource for you if you're still looking for more information on COVID-19. Kate, I'm not sure if you wanted to add anything to that particular aspect.
I don't think so. Everybody's probably seen those updates. It was a flood at the outset, and now it's probably a good thing that they're more infrequent, but we'll continue to update you as things evolve.
And so I know that several of you were able to join us partway through the presentation. So the presentation has been recorded, will be available to you. But if you do have questions, certainly you can always reach out to us at our contact, either the email or the phone here. I'm just going to quickly check our questions and see if we have anything to us. Peter, I think you may have you had raised your hand earlier. Did you want to make a comment?
I like it.
Awesome. We'd love to hear that. And, you know, if you have any questions, again, you can certainly always reach out to us. So with that, the next slide, Kate, if you could. There are some really great sessions coming up today that we would encourage you all to attend. You'll see the breakout session later today. So please make sure to join us. Again, if you have any questions, reach out to us. We'll make sure the recording is available to you. Otherwise, thank you very much for joining us, and we look forward to talking to you again.
Thank you.
Bye, everyone.